Good evening, everybody. It's 8 o'clock, and welcome to today's episode of Marvelous Medicine, which is about publicly funded health insurance. The speaker is Professor Sundararaman. He's an independent consultant, health systems and health policy studies at Puducherry. Dr. Sundararaman did his MD in internal medicine from JIPMA Pondicherry, where he went on to become a professor of the department. He was previously the global coordinator for People's Health Movement, Professor and Dean of the School of Health System Studies, Tata Institute of Social Sciences, Mumbai, and Executive Director of the National Health Systems Resource Center, New Delhi. Dr. Sundararaman was involved in the design and implementation of India's National Rural Health Mission, including ASHA Workers Program, the steering committee to draft the National Health Policy in 2017, the chairperson of the committee that drew up the blueprint for India's shift to comprehensive primary health care, including Ayushman Bharat Health and Wellness Centers, and the chairperson of the Technical Appraisal Committee of the Health Technology Board India, and last but not the least, the chairperson of CM's Comprehensive Health Insurance Scheme Review Committee, Tamil Nadu. He continues to play an active role in civil society organizations and has built and guided a science and health movement. You can follow him on Right to Health Resources Conversations on Health Policy. Thank you so much, Dr. Sundararaman, for immediately accepting to do this session. Moderating the session will be Dr. Shankar Prinja, Professor of Health Economics, Department of Community Medicine and School of Public Health, Postgraduate Institute of Medical Education and Research, Chandigarh. He is formerly the Executive Director, HPNQA of the National Health Authority. Ayushman Bharat, PMJ, Government of India. Dr. Shankar Prinja did his MBBS from Gandhi Medical College, Bhopal, MD Community Medicine from Pandit V.D. Sharma Postgraduate Institute of Medical Sciences, Rohtak, with gold medals. He went on to do his MSc in Health Policy, Planning and Financing from the London School of Hygiene and Tropical Medicine and London School of Economics and Political Science. He has around 300 publications to his credit, many on the topic of publicly funded health insurance as well. Has written several book chapters and has published a handbook of health system costing. He's on the editorial board of PLOS One, Pharmacoeconomics Open and Indian Journal of Health Technology Assessment. He is part of several research projects in collaboration with national and international organizations, including the World Health Organization and UNICEF, and has held important positions in the Ministry of Health and Family Welfare, Government of India, Government of Punjab and Haryana, and Public Health Foundation of India, among others. The recipient of several awards, some of the latest being Best Indian Health Technology Assessment Regional Resource Center Award by the ICMR in 2024, Professor M.K. Seshadri Award by the Indian Council of Medical Research in 2021, and Vijay Narayan Award by the Indian Association of Preventive and Social Medicine in 2021. We are extremely fortunate to have Dr. Shankar Prinja with us. Thank you so much for accepting our invitation to be part of this marvelous medicine session. Over to you, Professor Sundararaman.
Thank you. I'm going to assume that Shankar will come in after I speak so that usually the chair will have the beginning words, but we will give him after, let also the audience come in. And I am going to invite Shankar, who has been actually the official part of the official director of this program for quite a period, and also perhaps the most extensive researcher on this anywhere in the world, to come in for answering questions and more take this as an opportunity, because I think to share the basics of this topic to a larger audience, and then let both of us will take the question. I start with this publicly funded health insurance, and I'm going to assume that many of you are being introduced to this for the first time, though in practice, all of you would have an idea on this. What is it that this term means? We have got health insurance all across the world, and many of them are publicly funded. But when we are talking about publicly funded health insurance, the first thing we mean is that all of these are tax-based or general revenue-based government financing. This is unlike private voluntary insurance that is based upon individuals paying a premium and purchasing a policy. It is also unlike things like the ESI or the CGHS, where it is a payroll deduction that pays the premium. There is a specific premium paid by the individual who enrolls in the scheme. Whereas here, it is a government which makes the poorest eligible for the enrollment. The eligibility is conferred by the government because the government pays the premium on their behalf, so to speak. We'll come to the details later. And then those who have become eligible have to get a specific enrollment card. Some schemes dispense with having to get the card, but most schemes invest that you do need to have a card to show to actually get the benefits. Just a word about its precursors. It started early with the Arogyasri of Andhra Pradesh, the Yashaswini in Karnataka, and then the RSBY program, as it was called, that started up in 2008 under the Ministry of Labour. So, whereas ESI was for the organized workers, RSBY was expected to be for the unorganized workers, has its origins in a parliamentary committee that was looking at ways of extending financial protection to the unorganized sector. By 2018, about 8 more states had started up the program, and RSBI had expanded to many of the rest. So in AB, there were lots of problems with that, and the Ayushman Bharat PMJY, Pradhan Mantri Jan Arogya Yojana, launched in 2018, said that it would take on the payment for the premium of those who were earlier under the RSBY, a proportion, and another proportion being paid by the states, and also incorporated the state schemes into it in a way that we shall discuss later. But one thing that one must note at this point is that this is very much part of what is called the universal health coverage agenda, the universal healthcare discourse that was set up from the global consensus in 2012 and subsequently endorsed as part of the Sustainable Development Goals. And a number of developing countries have set up similar programs. So India is not unique either in time or space, and there is PFHI programs in many countries in the world now, and they do very similar problems and issues. Now, what was the rationale for PFHI? The first, most obvious and most persistent and still most relevant is because financial protection has become a central goal under universal health coverage. Hitherto, when we in health talk of thing, we talked about improvement of health. We never talked about protecting people from the costs of healthcare. You can't do that in modern public health, not since the start of this century, where financial protection became a leading issue because impoverishment due to healthcare costs is a universal problem and it compromises the rest of your life. I mean, it compromises all the quality of your life. It's the second leading cause of poverty in some sense, even the first cause, because the first is lack of income. And also because the another reason was attuned to it was because providers, especially specialists, are in the private sector and this will help access them. But the real issue, there is a larger theory that also drives this, and we must be aware of it. So as we will see that how applicable it is, we will see. So the larger formulation that came with universal health coverage was that people are being forced to choose between a low quality, highly overcrowded public sector and a very expensive private sector. The introduction of publicly funded health insurance means the public funding doesn't go to the supply side, it goes to the demand side. And that means that people can exercise their choice, choose what provider they want to. And the more efficient providers, the more better, impressive providers will earn more resources, they will grow, and public sector exposed to competition will also improve. This is largely part of an ideological discourse, but at some point, this is a major driver in this understanding. And the one reason why from the very beginning till today, it always has this enrollment of both public and private providers. People keep asking, why don't you, public provider is anyway funded by the government, why don't you limit it to private providers? And there's a background to why they think so. This last thing, need for a second stream of financing, is something that was not there in the beginning, but we are coming to it now. Now, some ballpark understanding about Ayushman Bharat. Its target is the bottom 40% of the population, 12 crore families, or approximately 50 plus crore individuals. It assures a sum of 5 lakhs, that a floater per year per family. It provides for up to that. The actual reimbursement is amount spent. Then the secondary and tertiary care hospitalization covers pre-existing diseases, which is a big step forward, but does not cover ambulatory expenses. And as we all know, a lot of secondary and tertiary care does not require inpatient care, but that's not covered. An important element is its commitment to being cashless at the point of delivery. It's prepaid. You don't need to have supposedly zero payment. And paperless, end-to-end IT enabled and Aadhaar authenticated. There's a pan-India portability. You can presumably get these benefits all across. And the center supports 10 crore families in 30 states, but the states pay additionally in different extensions for it. So actually the program is much larger than what the PMJAY literally is. PMJAY is paying only one part of it. So here is this program at a glance. Okay. And you must look at these lines. So the government subsidized schemes covers 51% of the eligible population of the total population of the country becomes eligible. We will see that coverage is less than what they become eligible in. Social insurance, that ESI and this covers 10%, and private voluntary insurance 9%. So 70% of the population are presumably covered by some form of insurance, of which what we are referring to publicly funded programs is 51%, and there's a breakup. The state extension schemes cover 36%, and the without the extension schemes and with the extension schemes are there together, it makes, because it's the contribution of the state and the center. And we mentioned in crores how much it is also, so that you get an idea of that. The one caution is that what we are saying here, that 51% is covered and overall 70% is covered, doesn't quite work out, because not everybody who is eligible has got enrolled. And this gap, after accounting for the gap, instead of 70%, you arrive at a more modest 50% of it is covered. And there is a way in which they have arrived at it. This slide describes it. Okay, in some sense, I'm not going into the technical how they arrived at this, but this is basically the understanding it, which is still quite a phenomenal thing, because it wasn't there a decade back. 2010, 12, it starts up, and then it picks up in 2018, and now we are saying that a huge amount is covered by insurance, in addition to a public health system. Now, some of the process details, there's a hospital empanelment criteria, there's an online application, a physical verification by district committee and approval, over 16,890 public hospitals and 12,438 private hospitals, 13.74 lakh beds. Packages cover 27 specialists and 1949 procedures, and this many states have expanded and the number of procedures are much higher. And the claims cover almost everything: registration, bed, nursing, consultations, from 3 days prior diagnosis to 15 days after. This is, shall I say, the policy intent. And there are incentives for higher quality of care, for quality accreditation, for aspirational districts, for teaching institutions. These are also ways of ensuring that some of these institutions are remunerated at a more attractive rate on that. So this is basically the scheme on that. Now, one of the important features of this, and this is something because very often I'm not sure about the audience, your experience is, we tend to see the experience of what we are seeing in our state as the only experience. And what actually the truth is that the experience is very, very widely dispersed across the 33 states and union territories where there is a program. So first there are three modes. One is called the trust mode, one is called the insurance mode, and one is called the hybrid mode. In the insurance mode, an insurance company is recruited, procured through a competitive bid. And after they are paid, given that bid, a premium, whoever bids the lowest premium for the set of services and rules in the tender document wins the bid. And they will provide the service on that. There have been so much problems with that that it has moved to a trust mode where instead of an insurance company doing this job, a parastatal organization, a government by other means, a government trust processes the claims and makes the payment. And then there are increasing number. Now hybrid has gone up to 7, I think, where you have certain things paid for directly, usually the higher end things, like Rajasthan will say, if it is above 5 lakhs sum assured, then it goes to the trust mode because the premium will not cover these outliers. So that goes to the trust mode, whereas the rest of it is handled by the insurance company on that. So you have a different process. But this is not the only thing that changes. Of course, this is the main thing. The beneficiary database changes. We'll come back to that. The health benefit packages states are free to design and contextualize. Some states have outpatient, some states include transport care. Hospital empanelment criteria changes and the way administrative fund is utilized change. So you can see West Bengal and Odisha in this map is not shown as having a program, but that's because it's not having the PMJY program in this thing. There are state-specific programs with a very large budgets and coverage in these 2, 3 states. And Delhi has just recently joined, as we know, after the political change. So actually, the coverage is much larger than even what this map is showing. Now it paid for 1.99 crore hospitalizations and 1.08 crore in the private sector. And you can see that the overall turnout is a substantial amount on that. Uh, so these are the figures of that. One interesting point, and I'm making this slide. I'm just making a general point with it. The general point that I'm making is the pattern of utilization of services will vary widely between public and private hospitals and within private hospitals by district, and they do not necessarily conform to any standards of epidemiology. They will be much more related to the supplier variability and preferences within that particular area. This is a problem, but eventually some of the areas which are high utilized are anyway some of the areas which are required. So the top 2, 3 have a logic which is rational, the others are much more supplier driven. But this is one area of study because not everything that is included in the package is utilized, and not everything that is utilized is included in the package. And that difference one has to understand. And why some of them are utilized very marginally, though many cases require that coverage, relate to a number of access and supply factors that we will need to study. There's one more interesting feature. A number of states, and I think at last count it is about, I had the figure on that, have gone for universal coverage. When I say this, what we mean is that they have extended the coverage to 95% or above, or literally 85% if other insurance is counted. Okay, and that I think is something that is uh, quite important on that. I made my notes on this. I actually missed the point on that. So, for example, I think the states with so anyway, let me just go back a little bit on this. The other one, the one in blue, is where you have extended it to ration card coverage. So those which have uh, ration card equivalent are which will be usually not only the poorest ration card, the other colors also. So it will mean about they will be between 65 to 80% of the population they will cover. So universal coverage is 95 and plus with 85 to 90, but this is 60 to 85 or 90 is in this blue line. And only the SECC is the uh, socio-economic and caste survey that was done in 2012. It's really outdated. But at some point, that is what the PMJY committed to pay. But since that survey is so outdated and the census didn't take place, the PMJY said that states are free to develop their criteria to choose the numbers who were there when the SCCC was done. There's a little bit of ambiguity in there. And therefore, a lot of people get in who should not be there, but a lot of people who should be there are not there. But that's a different problem because anyway, the states are promising, more and more states are promising universal coverage. So yes, I have taken the effort to say these states have said, no, we are not limiting it to the poor 40%. We are going to cover 100% or at least close to 100%. And they have devised many ways of doing so. The commonest is to say the government will pay for everybody. Like recently, there was an announcement that all those above 70 years of age are covered. What does it really mean on the ground? We will come back to, but that is the sort of issue. In others, like in Rajasthan, they said those who are in above poverty line, they can join the scheme by paying a premium equivalent to what the via government is paying for others. Okay. In Karnataka, they said the above poverty line people can join, but they will have to pay 70% of the cost. We will subsidize 30% of the cost. Is that is that a useful thing? 30% is not much, but it is useful because in international parlance, insurance company negotiates the cost package for each service. Since it's a negotiated price, it's likely to be a better price than what they will get as an individual patient in the market. This is one of the big problems in the area. When, as a patient with an emergency, you go to a provider, you're in no position to bargain and you don't know what is a fair price. So at some point, this is bargained, and therefore a 70% cost is basically giving them the benefit of a bargain package. So Karnataka's scheme differs in significantly different ways on that, and that I think is something that we note on this. But eventually, what we are saying is that there are many states that are aspiring for or have claimed to have achieved 100% eligibility, if not exact coverage on that. Now, this is the storyline. This is basically the what is the government intent? What is the policy intent, as we can say? What is the practice? How does it turn out on the ground? And India is a strange country. I my own speaking is on a little bit of research work I have done, but largely from my students. The most recent one was published as recently as May 10th, just 2-3 weeks back, and it's the most recent data set. The first author is a assistant director in the Department of Statistics, was a former student of mine. Now she's associate, and this is working with official data. So I'll be able to give you a sort of reasonable picture of where is the situation now with PFHI schemes. And we started with an earlier program on government strategies and utilization with some of these. So the point I'm making is there is a lot of studies in this area. This is all by my students on this. I had two doctoral students who worked on this theme, and we have between us a lot of things. Nothing compared to Shankar Prinja and his 300 papers, but I mean, Shankar Prinja is in a league by himself, and a whole lot of his doctorate students have worked under this. And related to that is the other problems of financing, because PFHI is never studied in isolation. You look at public funding, public provisioning as a form of insurance. You look at other means of achieving financial protection as a use of it. And you also look at people who are too poor to access care even after all these means. Now, let me look at what is the main finding from this. Uh, I'm sorry. Uh, let- I'm trying to get, uh, yes. Now, hmm, I'm unable to shut down is covering my the figures over here on this. So in some sense, uh, difficulty in this. Let me try to say this is the recent survey. And what does it show? It's a fairly large survey, household consumption expenditure survey, specifically asked whether they had an insurance coverage, what coverage it was, and specifically asked whether they utilized that benefit. So many people have the card but don't know whether to utilize it or don't, it's not been called into use, it's not been offered, and they use that. And what we see is 25.2% were enrolled in a scheme. This compares with the eligibility of 50% to be eligible or actually claim to be covered. So this is 25.2%. I am told that this year's survey has raised it to 35%. That it's better now. But this is because a lot of people who have the card are not quite aware what the card is and what it needs to be doing on that. And that's one problem that is faced. And then you have the problem that of the enrolled, not all of them need hospitalization, and only 6.82 needed hospitalization and used the benefits. But of the 35% of hospitalization in enrolled households, only about one third, I mean, only 35% use the benefit. So if you're enrolled, you should are entitled for the benefits and you need the benefits, then about 1 in 3 only got the benefits. That's not good. But if you look at all the people and you are looking at your aspiration is the entire coverage, then only about 9% of all hospitalizations got the benefits on that. So in some sense, it's still a very, very modest figure. The, this is a very detailed study with a whole lot of statistical studies in this. What it shows is that enrollment was higher in the more marginalized. So the people who were doing the enrollment did reach out to the poorest, and they are marginalized by virtue of lesser income or lesser education or lesser employment or more unorganized employment. All of them had a higher enrollment, but the utilization rates were better off in those who were less marginalized. So the richer among this section utilized it better if they were enrolled, but those enrolled was, well, it was pro poor on that. And it also shows a very high variation across states. So this variation is very wide. So when I'm presenting these averages, I'm a little bit worried that it doesn't respect it. So you can see enrollment has increased by 2% the access. So if access was the main aim, it's a modest increase. The shift to utilization of private care is also a modest 41 to 46% with enrollment. So as the PFHI providing access to private providers, it's very modest on that. What is a bit worrying, and this is really a matter of concern, is that actually out of pocket care costs are much higher in those who are enrolled. Now, this is a problem of surveys, and there are many other surveys that have looked at it. So, this is an overreading of the situation because the mix of patients that we are seeing over here, it is more likely that the card was used with more serious patients requiring much more high tech care, and therefore it is higher and not quite true. But on the other hand, we have from a number of studies, which I have not got the time to go through, we are finding that what effectively people get is something like a discount. They get something like a 30% less out of pocket expenditure than if they had the card. Without the card, they are paying some 30% more. Cashless service is a mirage. We are not really anywhere near cashless service. There is a small subset of hospitals that do provide it. Here, there is also a phenomena of both, that many people went to private sector, couldn't get treated, and went to public sector. A few went to public sector and couldn't get treated and went to private sector, and how the expenditures moved across them. Catastrophic health expenditure is a measure of how much distress your expenditure crosses. CHE 10, catastrophic health expenditure 10, means that the expenditure was more than 10% of your annual income. So for the poor, a lesser amount will affect more, and therefore it's a better figure to use than out-of-pocket expenditure, which may have come from the richer fellows. And you can see again that catastrophic health expenditure has not really reduced. So at the end of the day, financial protection at best is at a discount level, and access is marginally increased on that. It's not that the government is not aware of this. This was a major part of their 2018-19 electoral campaign. This was part of the manifesto. In the recent campaign, it played a much lesser role. People are aware that there are many problems that are coming into it. So there have been ways in which the system has been trying to cope and reconcile with these problems on that. First, there is a shift from hiring agents, insurance agencies, to empaneling and to empanel hospitals. It's the shift to trust mode. Many of them started with insurance agencies and now they have gone to the trust mode. Second, when you are having a trust mode, you are having huge cost overruns. On an average, about 100%, 150% over the budget. Okay, and therefore, at some point, trust modes are very frequently budget overruns, whereas insurance modes have the opposite problem, too many denials. To cope with moral hazards, like you will find a huge number of hysterectomies being done with very limited indication. You can't defend it on an individual case, you can defend it. But when you look at the population percentage of utilization of cesarean sections, even something like knee and hip replacement, they tend to cluster into huge numbers on that. So many procedures that have been shown at the population level to be associated with moral hazard, unexplainable overconsumption, have been reserved for the public provider. And that has helped to bring down those costs, etc. It's also a way of keeping capacity in the public sector available. And then an increasing problem is private providers, many of them exit, especially if the monitoring is very tough and nobody is happy with the pricing. At some point, the packages, they would say, are far too unremunerative. And if we don't charge that extra money, we will be at a loss. And here there is a big concept. I'll just come back to it a few minutes later because I want to keep that thing and close with that because I'm sure to many of you that is the big issue on this. What about the cost? Now, why do we have such a problem in performance? Where is the difficulty? So first is a set of difficulties in access. No card or card not used. There are still tribal hamlets, fisher folk, very poor people, marginalized, urban slums where the card has not reached. Second, and this is the services are not available in every hospital. Just because you have a card doesn't mean you have a service, especially when we are talking of the sort of services that are high end. And sometimes it's reserved for the private public sector, and sometimes it's not. And which private person get it? In the remoter areas, you don't have a provider who knows that. And therefore, a person with a card at the time of his sickness cannot locate it. If you ask the officials, they say we have a website, we have a call center. They're not quite effective to do that. And locating a provider is therefore a problem. Then public provider denial is a problem. By rule, public providers cannot deny, especially where there are no user fees. On high-end procedures, an informal rationing always occurs. There are waiting lists of 3 months, 6 months, 1 year, and therefore the person with insurance is likely to make it to the list. The person without insurance will get pushed out of the list on that. And therefore, there is a significant amount of denial that is taking place on that. Private provider denial is even more thing. It's other than charging. If let us say 60 people in one hospital I visited as part of the official inspection, there were 160 patients, of which not less than 100 patients had a card and were eligible for receiving benefits. Not more than 10 people were getting the benefits. And the private provider was cherry picking whom he gave the benefits to and whom he did not give the benefits to. And legally, it's a gray area. It's a contractual violation, definitely. There's a contractual obligation, definitely. But a private provider is not legally obliged to give care to everybody who comes into the door and offer the service. So to enforce it as an entitlement is a problem. And then the insurance company's denial, usually on a lot of procedural grounds, like within 48 hours you did not file for the pre-authorization, and there was within 3 days of discharge you did not file. These are procedural ways of managing the budget, and then denial of cashless service, double billing remains a major problem on that. There are also budgetary inflexibilities. There is a certain amount of money within which people have to manage. So, if you are in a trust mode, it's a cost overrun. If you are in an insurance mode, the sum of the premiums is your budget. And therefore, if you add anything into the package, it displaces existing schemes or patients who would otherwise get it. And insurance companies have a hard time doing it, and they are accused of a lot of denial, and that's why they get replaced. But eventually, the budget matters. They're very selective coverage, a lot of ambulatory care, a lot of virtues within even inpatient care get excluded. There are supply side iniquities. For example, the providers are located in Chhattisgarh in the urban cities, but the premium is being paid from the tribal fund and the scheduled caste fund, and many of them are located in the rural areas. So money that is earmarked to them is paid as premium, but because of access issues, the people who are able to benefit are the people who are better off within this. And that's why you get that utilization is better in the better off section, whereas enrollment reaches everybody, which is not a very good situation because you have actually got a premium out of the poor, though not something out of their pocket, but out of what was earmarked for them. But the services have become iniquitous on that. And then there is the insurance provider interface, and then come to this issue of package rates. I think package rates, Shankar Prinja is both the best person to explain it and also the best person to be held accountable for it, or nearest person. Even he is not accountable in government, difficult. But I must try to explain this particular point and I'll rush through the rest. There's a difference between a marginal cost, an opportunist cost, and a price foregone. A marginal cost is if I am seeing 100 cataract patients, I have my build office hospital for that, and I have my staff for that, and 101st patient walks in. How much more do I need to spend for that 101st patient? That is the marginal cost. Internationally, marginal costs are the usual basis of reimbursement. Okay. So therefore, to expect if now, I think in India the marginal cost is about 8,000 to 10,000 rupees. That will be about per eye per cat. Then if you go at opportunity cost and say, no, 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 we'll have to break even. That means even the capital investment we have made, even the building that we have made, that cost has to be recovered. Then I think the latest package they have, they can recover the cost, including capital cost, within 4 years, and that's the opportunity cost. That's higher because it includes capital expenditures and not marginal costs alone. So that would mean about 15,000 rupees per eye. On the market, I charge 50,000 rupees per eye, 45,000 rupees per eye, 1 lakh rupee per eye, and then the replacement for the provider. He calculates its cost, his loss on the basis of prices foregone, whereas we would be saying, no, no, we paying enough on that. And this particular difference is a very serious difference, and why you are not able to get anything going. Now, there are hospitals which are running at 50% of their capacity. And they therefore find this useful, because some places, like I found in Jharkhand, in Gumla district, there is a mission hospital, it is 50% of its capacity because there are patients, but they are too poor to pay that minimal amount. And they find this actually a very remunerative. Or let us say Shaheed Hospital in Chhattisgarh has a huge amount of turnover on this because they find it, they have marginal capacity and marginal cost, therefore works for them. But if you don't have marginal capacity, if you're a hospital which is already overcrowded, 110%, Apollo is as crowded as any general hospital, then it is a loss for them. They will look at the prices foregone. So this actually has a structural way in which you need to look at them. To come to the positive side, there are major strengths. Now everybody is getting a digital card, a digital architecture has got built up, human resources on management has built up. The nature of financing for public hospitals, especially for high-tech cases, has improved. There is a format for engaging private sector on a voluntary basis in public health goals, and there is a grievance redressal syndrome. There are more things that can be done, but for the if universal health coverage and right to health care is a goal, then PFHI has actually built up the infrastructural base towards going to that. There is a big argument about should we fund public hospitals or not? What is the case for and what is the case against? When I was on this committee, I started with my presumption that it should not be funded, it's just double funding, etc. And hospital after hospital I visited in Tamil Nadu, which is the best hospital, and I had this question and conversation going. I came off convinced that they really need this funds on that. This decentralized, flexible funds, the increased volume. So they were saying, look, the gynae department and general surgery, it's okay. But when you come to high-end procedures, when you come to transplants, when you come to high-tech procedures, we just don't have the space. We would be the last priority unless these funds come in. It has opened up the public health capacity in a major way. And it stabilizes the prices in the private market. You can see that many of the services that private hospitals are willing to offer are those where there is a competitive provider in the some other sector. Where it is a monopoly situation for the private market, then it goes up. So, in some sense, to actually create a competitive environment on that, and it builds institutional managerial capacity. Even in ZIPper, the entire understanding of costing, financing, digitization, the way in which this whole moves, it has moved the whole process of financial management in many ways. So, collateral or intended, there have been many gains. But the great danger is it's a huge administrative load. It draws away from your teaching programs. You are expanding services without staff or infrastructure. The worst part of it is introduces private behaviors into public services, distorts the nature of care. There are dangers of exclusion on identity basis, and these take new forms on that way. We were saying that at some point. So it's a mixed bag. I'm not very convinced. There is a line, like I know from Thailand, where they give group incentives. where the incentives are given to the department, which they use for academic activities or skill-based training, but not to individual providers. That would be resisted. But having said that, where it has been introduced from the beginning, it seems to have worked well. Where you have the reverse program going, where they do not, the hospital does not hand over the amount to the department, gives no incentive at all. That's very negative. Their argument is we are earning this money, and why should we will reduce the budget from the which we spend from the government. But this is only government money. It's tax based, both are tax based financing, whether it comes through the direct channel or through insurance. The question is, which is the more efficient way to allocate and use it on that? So finally, in terms of what can be done about the crisis, here is a potentially good system, but facing a whole lot of bottlenecks on that. And we were looking at that. The first thing is navigation support, help from the to the patient, and it can't be just at the call center and level. It has to be to the primary care center, and with some commitment that if a person, it should be treated as an entitlement to that care. And if they cannot get care in the hospital where they have first resort, there must be a system of being able to transfer them to the next nearest place which has marginal capacity. And that is actually the right to health care. I mean, whether you call it that or not, you call it that. The fact that a hospital goes on pass and says, I can't do more than this, and therefore the next hospital has to pick up that load, that sort of system, we have the digital basis to do that. We have the rest of the structure to do that, but we need to do that. And then we can use this for much better demand-based financing. Today, there is a lot of inefficiency in in public funding. A hospital, district hospital, which has 50% bed occupancy and is seeing 200 patients per day, will get the same amount of budget as something which has got 1,000 patients per day and 150% bed occupancy on that. And this actually balances this out, but you need to work this out. And even if all private providers don't particularly join in, the more ethical, the ones with more marginal capacity, the people working in more difficult areas will. And if we start that way, especially as new people join up in the private sector, you can build a culture on that. Too much urgency to engage everybody is also a problem on that. But we also need certain things. Procedural lapses as grounds for refusal. We really need to get cut through this immediately. I mean, if an intern fails to submit the form within 48 hours for a discharge claim, how can the patient be refused his entitlement? There's an ethical problem in the way procedure. If I'm buying private voluntary insurance, then the fact that these things are not followed is potentially a choice that I have made between different private providers and paid for a better package. In practice, even there, you cannot read the small print. But there is such a fiction. But in this situation, you have got lot of stipulations on the provider, which providers have to fulfill, but it is not the provider who pays out of his pocket. It is definitely the public. And any notion that the provider should anyway give free care and then get the reimbursement has a real problem. And that's why private providers are exiting the scheme also in a major way on that. So I think that we need to include the top, the above poverty line, their voice, the amount of political voice they bring in will matter. But there are problems. I have seen in some places, let me state it, in Meghalaya, for example, the top the section uses the best hospitals in the private sector with this scheme, whereas the poor are going back to the public hospital with much less coverage on that. The terms of engagement with private providers, there are some ground rules for it. Should be voluntary, based upon a model code of conduct with different issues. And integration with primary care is an extremely important forgotten element of this, because it is we are picking a fragment of care. When we are picking up coronary heart disease, we are not insuring patients against coronary heart disease. We are insuring them for stent or bypass surgery. It is not the management of coronary heart disease or hypertension heart disease. It's just a procedure that is being insured again. And there's a problem with that because all care is not a procedure, requires a prior follow up and a following up afterwards, and the systems to do both of that are not there. That is a different type of inefficiency, meaning if I do a knee replacement and do not provide the physiotherapy afterwards, the clinical care I have done does not achieve the outcomes it is intended for. And therefore, the link of primary care is also a way, the lack of a link is also a wastage that we can overcome on that. But potentially, I mean, even though there are so many problems, and I actually presented these problems in a stark way, and we deal with that, potentially this leapfrogs us into a way in which, if the political will were to materialize, we could actually move into universal health coverage or right to health care would become a possibility of that. That I think is the excitement in this. Despite all its problems, despite its non-performance, there is a direction here that needs to be revisited and worked on. Thank you.
Thank you very much, Sundar sir. I think excellent talk. I've always enjoyed your lectures, and this has been no exception at all. So, thoroughly enjoyable. I think I got a lot of new insights, especially the recent work that you published. I think overall, you've given a very balanced picture of the entire story, starting off with the kind of basic concepts and trying to distinguish between the real essence of what this tax financed health insurance schemes are, vis-a-vis a lot of other social insurance schemes and voluntary private insurance, which inherently brings in a certain degree of inefficiency given the voluntary nature of enrollment within those schemes. And a lot of the information, I think, I'm sure the participants would have found that it's a very rich source piece of information that you have brought out in terms of the basic design of the scheme, etc. One of the points I think that is also important to recognize is that we live in a federal structure. Our country, in the kind of governance architecture that we have, we are in a federal structure. So while a lot of the scheme design issues do get conceived at the central level, there's a lot of flexibility at the state level also that is given in terms of the implementation. And I think that your slides did bring about a lot of those specificities, such as differences across states in terms of the governance structures, whether it's a hybrid mode or a trust mode or an insurance mode, or the way in which the whole health benefit packages are implemented. But one of the important things that I just thought it also needs to be emphasized is that a lot of times that these health benefit packages, which includes the description of what services get covered, at what prices are the providers going to be paid, this entire architecture gets revised on a reasonably periodic basis. There have been about nearly four revisions of the health benefit package that the scheme since the inception has undergone. But interestingly, a lot of the states, given the fiscal implications of adopting newer packages with newer and better rates bring in, they continue to stick to the older rates. And so a lot of the general perception and discourse around the prevailing prices and the given the 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 discontentment with those pricing structures, they remain because the states continue to work on the previous package rates, whereas there has been a lot of evolution in that at the central level. The other point before we open up for discussions and taking the comments in the chat box as well, is that while majority of the study, so the broader learning from pre-PMJY studies was exactly what was shown, that the pre-PMJY, all the government funded insurance schemes like the RSBY and the other state specific schemes, they led to slight increase in utilization, but they did not have any impact on out of pocket expenditure, and rather the out of pocket expenditure increased. But since the since the PMJY came into being, there have been a number of studies that have been published. A lot of the studies that I think Sir has also shown, and majority of those coming from Chhattisgarh, they do show that the kind of enthusiasm that it infuses in terms of the scheme being able to reduce out of pocket expenditure has not been as phenomenal. However, there are still some other studies on specific disease areas or other geographies that do show that there is still um, some benefit in terms of reducing the out of pocket expenditure, despite the fact that it is not at all completely cashless. And there are reasons why the scheme has not been able to completely ameliorate the extent of out of pocket expenditure. They still continue to remain. But these other studies do show, some of which we have published, do show that there is a reduction in out of pocket expenditure as a result of the scheme also. So before I continue further, I think let's now open up for comments and any questions or clarifications. But sir, if you have had a chance to look at some of the questions in the chat box, so if you would like to respond to any one of those questions, some of these questions were more related to uh, the basic kind of there's some people started commenting on the basic thing that do we really need an insurance? And I think you tried covering it towards the last part of your slide. Do we need an insurance to justify the coverage, and is it not a mandatory requirement of the government to be able to provide? So maybe if you would like to start with that kind of philosophical note, and then we'll take the other questions as well.
So the issue is government's public provisioning. If I provide free care in a public hospital, that is also insurance. That is an insurance where the tax is from the premium, and tax is a very equitous way of collecting premium, because the rich pay more and the poor less. And anyway, the poor pay in indirect taxes, so it's not as if the poor don't pay. So in some sense, they are collecting the taxes, and then for delivering care, the mechanism is the public hospital. The question is, therefore, I'm not going to place this as a thing about insurance. It's about which is the best way to channel public financing so that it is just the maximum value for its money. I don't think that we should replace or think of this particular thing that it is the public service is going to become more efficient, or while people can move to private. The private purchasing from private care is an alternative to public hospital care. That I think has been conclusively debunked by the experience of this whole thing. In fact, the danger is of not losing the private altogether. In some sense, that has been debunked. The question, therefore, is how best we use the public money for whatever level of money. I mean, if I have 2,000 crores, if I have 1% of the GDP, if I have 5% of the GDP, how do I get the maximum value out of it? How do I as a finance? And therefore, insurance does have the advantage that is much more responsive to the consumption pattern than what normal government financing will be. So whereas things like infrastructure, some core HR, equipment, some of these will require to be provided by a different mode, by the budgetary mode, as they call it. You will need to pay some of these amounts by this as a way of being able to distribute across it. Okay. You need not give it on a fee for service mode case by case. Thailand, for example, is based on this issue. The Thailand looks at the total expenditures on inpatient and outpatient care of the previous year and gives you that same amount in 2 or 3 installments, meaning it uses it as a way of calculating your budget. It's called a universal coverage scheme. It's called an insurance scheme, but they don't give it for each. You have one surgery and so much, and each one you process a claim. No, you maintain an overall record. They inspect that, they find it, and they use it as the basis of allocation between that. Outpatient is slightly different, but for inpatient, it's the basis on which they do that. So I think that as a form of resource allocation. Then again, as a thing, there are many situations where you need to purchase care from the private sector to supplement the gaps. It may be because the public sector is overloaded, in which case, like we happened during the COVID-19 period, when people were universal healthcare suddenly appeared, no, because it was a problem for everybody. At that time, you would refer a patient and where they have capacity and reimburse them, or for emergency care, you the commitment to reimburse them at a fair rate is a necessary part of that. How do you fix the fair rate? How do you do that as a fair rate? But I don't think just you cannot wish it away and say we'll do. It is public financing that is important. It's not. It's not going to be done by people paying out of pocket care. That is the most inefficient and unfair and unjust way of paying for care. But that is still the dominant way of paying for care. How do we get out? It cannot be private voluntary insurance. How do we actually solve that? That's the issue.
Right. I think that's a very fundamental point, I think, sir, that you've made. There are few factual sort of clarification questions. I'll just respond to some of them and then come back to you again for a very fundamental question. So some questions around infertility treatment, whether they're part of the scheme design or not. I think as the scheme was designed and conceived, some of the things were kept out of the overall purview of the package, and infertility at that time was not considered as one of the things that would be covered within the scheme. Although in recent times there were some discussions around consideration of whether infertility treatment should also become part of the scheme. The Tamil Nadu model of transplant services being reimbursed through a kind of a corpus that is created through the from the as a proportion of the funds that are to be paid to the public that is created. To my understanding, and I'll let Dr. Sundararaman also comment on that. I think, to my understanding, it's a quite a novel initiative, whereby there is a certain proportion of the funds from the public hospitals that is created as a corpus, kept as a corpus, which is used for either infrastructure development or for subsequent payment of more high-end procedures that may not get covered within the scope of the services. I think fraudulent practices are also, we do recognize, and I think Professor Sundaraman did mention that these continue to take place. There are provisions, but the nature of the demand side financing is that that these fraudulent practices, while you may continue to keep checks and balances, there is a perverse incentives on the part of the providers to perhaps engage in some kind of fraudulent practices. Gatekeeping by essence, and there's a comment about whether the gatekeeping is good or bad in the context of Madhya Pradesh and Chhattisgarh. I think that the whole concept of gatekeeping was that you reserve certain packages, certain services to only the public sector. And the reason why this concept came in several states was because there was a perception that perhaps this might become a channel for kind of diversion of public funds to private provisioning. And for at least the services which the public sector is equipped to provide and has the capacity to provide, at least those services, there should be a certain degree of gatekeeping, with excess demand being flown towards the private sector. So it was with that intent, but there is definitely there are certain negative consequences of that gatekeeping also, in terms of perhaps access to services and also the kind of expenditures then the patients have to incur when they reach to the private sector. I think I'll move back to Professor Sundaraman, because, sir, I think you made couple of points towards the end. One was related to continuum of care. I think that's a very fundamental point, and linking the two pillars of Ayushman Bharat, the health and wellness centers or the Ayushman Arogya Mandirs, and the the secondary and tertiary care provision through the PMJY. Is there any kind of model that you would have knowledge of which has shown to be as a kind of a pilot which is viable, which can be replicated? Because I think that that's something that is the futuristic thing, and that needs to be there for two primary reasons. One, to decrease the load of hospitalizations that come in because you track patients early on, and the other is because it also helps to reduce a lot of rehospitalizations because of complications that arise among those who are being treated. So back to you, sir, of if there are any
So,
insights on that.
so I must say that this it's interesting, because continuity of care can potentially be solved without solution I'm going to highlight. But I'm highlighting it because all the examples I know, Ireland, Costa Rica, even you look at UK and the NHS Act, you look at all of them depend upon A, the primary provider as the hub. At some point, the person who refers and who is in charge of the referral. In Thailand, the first referral from the primary care to the secondary care is actually paid for by the primary care provider. So that the referral happens. If the secondary care unit takes over the patient for care, then the reimbursement goes to the secondary care provider. So that happens because there is a right to health care. You can enforce. These are different. Look, individual providers are different providers. They are private people. You can persuade, and there is a big role that persuasion can play. You can use digital tools, and that is a big thing that digital tools can do. But eventually, it is not the bridge, not the digital pipeline, but the people at both ends who need to feel an obligation to work together. And that works well best in a place. So, all the countries which have some right to healthcare in place have been able to enforce a continuity of care, which otherwise is not really enforced. In India, Meghalaya is actually full of interesting experiments now. It's got a leadership which is doing that. They have brought in primary care into this. And they are working on this situation using much more a structure of institutionalizing continuity of care through various ways. But they still have the problem that what if a private provider says, no, I'm not interested. And what is the purchase you have? So it has to be within the public system. And as we say, the public system is already under a certain type of stress and it doesn't have the range of care. In Meghalaya, they actually don't have enough specialists all over the place. So they can't even manage it within the public system. So it's work in progress. I don't think continuity of care has been solved adequately in countries without a right to healthcare thing. And in India, we have been trying, and I think everybody is seized of it, but our progress is very little of that. Even if, for example, in the big medical college hospitals, you have huge crowds waiting to just collect their epilepsy drugs or collect their diabetes drugs or collect their anti psychiatric drugs. If even these patients can be shifted back to the primary care and you can ensure that they can collect their prescriptions at the nearest center which is now equipped to deliver it, it would be a big blow in favor of continuity of care. If dressings which are required for a patient can be done in these things should happen even now, even within the issue, but it's it's very difficult to bring. Also, what happens? The medical college is under one directorate. The district hospital and CHC is under another directorate. Then the primary care provider is under the third directorate. So within government, to if with the private sector conversation is difficult, even between directorates it becomes difficult in public sector. I mean,
I think that's a very important point, sir, that you have raised. And so interestingly, we were also having a similar kind of a conversation in the context of Punjab state, and we were discussing this with one of the policymakers of this having this continuity of care. And what we were trying to argue was more in terms of continuity between the primary, secondary, tertiary, etc. But the point that he made was very similar to the one that you are making actually. That perhaps a more low-hanging fruit in terms of ensuring a continuity of care is to ensure that the individual who's been diagnosed with hypertension, diabetes, and other chronic diseases, they at least are able to get the kind of medicines, etc., on a more continuous basis at the center which is closest to him, which is the health and wellness center or the Ayushman Arogya Mandir. So after a prescription which is provided by a doctor, at least the continuity of drugs is at least ensured and the compliance to treatment is there and a control status is achieved. I think that to his mind as well was a better first level of continuity of in terms of care that he wanted to ensure. Uh, Moving on, I think there are two important, very different but important issues that have come up in the chat box. One is related to a kind of merger of the larger risk pools. And I know that you have a whole body of work around the ESIS scheme as well. And but there is this point about the CGHS and other schemes also running in isolation for different set of population groups. And then we have this PMJY covering the SCCC bottom 40%. So is there a rationale? And if yes, then what is the way forward for any kind of a convergence across schemes? And if at all this convergence is to happen, then at what levels should the convergence take place? Just at the design implementation or even at the level of risk pooling? So that would be one question I'll leave to you. But maybe after that, another question which is not related to this, but is around the kind of there are a lot of questions around the fraudulent practices within the private sector. But I would rather say that while these do continue to exist, and there's no denial of that, is there an opportunity from the scheme design or the implementation itself to be able to use this as an opportunity to rather regulate even the private sector and the kind of market structure? So I leave you to those two questions around convergence and the kind of opportunities that the scheme may provide for any kind of regulation in the private sector.
You know, regulation must be taken on its own right. If you mix up regulation with uh, implementing the scheme and implementing right to healthcare, you will mess up both. Because regulation requires much more negotiations, much more careful incremental progress, much more trust between the government and the different providers. And it also differs. So I don't think that there are clinical establishments act which have very weak rules and even weaker implementation. And they are managed by some people. And I think we need to move on that. Here, and that's why I made this point. Here, private sector participation, we should insist is voluntary. Only those who want to be part of the scheme should be there. Regulation implies that somewhere the Japanese do that. They actually outlaw private profits in healthcare sector. They can do that. The South Koreans do that. The Germans do that. But we can't do that. And it's not very easy to actually get that sort of a purchase on the private sector. It's also a different history. So all we can insist is that if people come into the scheme, they are under a contractual obligation. And if you grow enough people who are within this frame of mind practicing within a particular way, then you would be able at a later part to bring in some issues. Even in regulation, we should look at some issues which are clear conflict of interest. Like my favorite is the kickbacks and commissions nexus. I think that's the real problem. I don't think we can really start looking at delicensing and licensing and looking at the effectiveness of care. There are medical negligence is another box. People confuse medical negligence management with Clinical Establishments Act, and they confuse Clinical Establishments Act with Purchasing Care. These have to be handled separately, and I think mixing them up will be to the detriment of all of them. So we will deal with regulation separately. The entire experience is interesting, but the response thing is more interesting. Uh, Germany, for example, has always had multiple risk pools, okay, which is different from, say, the Canadians and Australians who have a single payer system, which is a different thing. But Germany has a way of equating between risk pools. So people who are on a much more wealthier thing will have a larger budget corpus, and people from a poorer section or who are unemployed will have a lesser system, and the government does some transfers within that system. And the interesting thing about all social insurance thing is that they all have a surplus budget, you know, as compared to all of us in the other sections who are always saying we are starved for budget. So ESI, for example, very few people know that, has a 1.47 lakh crore corpus, which is gained from premiums which they have, let me use the word, unable to spend, and their report only brags that they have got their insurance, the interest rates they have raised from 2.5% to 6.5%. What? On money that should have actually been handed out as benefits. Because these are people who by definition are earning less than 25,000 rupees per month, 21,000 rupees per month. They're the poorest people. So I don't know what we mean by merging risk pools. There are risk pools over there which are already underutilized on that. So again, we must look at best practices, and in the developing world, the Thai do it well. Second, don't expect the CGHS to actually merge its risk pool with others. Even the ESI has a reluctance, but what you can do is to actually synchronize at the level of service delivery. So if you deliver services, and this is going to be important in interstate movements also. Delhi has a problem. If you ask to give free care in Delhi, most of the people who benefit will be non-Delhi people, because people from all surrounding states come there. So that the care at the facility is provided free, but depending upon your background entitlement, the reimbursement comes. So if you go to a hospital, you provide free. But if you are enrolled in ESI, then ESI will have the first preference to actually have pay for it. And then you will have if ESI card is not there, then you have, if CGHS will have, whichever is the larger pool, you will deduct from that. And then you will deduct from ESI, and then you will deduct from PMJY, and then it is out of pocket payment. But now the problem is each one has a different set of rules. Each one has a different set of packages. I'm saying even if we limit to saying if this is eligible in the ESI package and he has both a ESI card and a PMJY card, the first debit should go to ESI. It's not a very difficult thing to arise. The digital systems allow that, and the ESI has the surplus. It has the money to pay for it. So this way you would be able to synchronize it. The problem with these things are these could have been done yesterday, so to speak, and it's not something that is very difficult to do. But because of all your Aadhaar and your this and that, you also know who has the ESI card, who has the PMJY card, who has this card, CGHS card. So if a CGHS person walks in, and then the CGHS budget gets deducted, whether or not he chooses, because the commitment of the facility is cashless care. How the facility gets reimbursed is based upon the backing of the system. And I think that works in Thailand. As a result, they have actually more or less coming to a point, not yet merged it, but they have coming to a point where the ESI equivalent, it's called SSS there, and the PMJ equivalent, which is UCS, is more or less now on a merge plane on that. Whereas you can't really touch the CGHS equivalent because the whole military budget is also there. And, nobody touches the army in these places and gets away with it. So that's privilege. So The central services, like you are saying, if you want to think of getting the defense forces and railways into risk pools, defense forces is a big risk pool, but nobody can even suggest the idea of merging it with any other pool. So those privileges in the real world you allow to exist, and there is enough you can do with the rest. ESI is actually of very poor people. Many of them are taking care from the primary health care centers because the ESI dispensaries are far too few and far too underfunctional.
Right. I think that what the point that you brought out is, I think, very relevant. That when we start talking about the convergence across risk pools, the convergence in real sense, it's going to be much more difficult at the level of the risk pool. It is going to be more a convergence across the design and the implementation structures, possibly. So, and that in itself can also lead to a solution to a lot of problems. So, for example, and I'm speaking more from an implementation experience, that given the differences in the kind of packages, the package prices, and the hospitals that are empaneled in itself, that creates a huge amount of perverse incentives at the ground level, because if there is a patient, if there are better prices that are offered in a particular scheme, then obviously the providers are more inclined towards provisioning of those services and those category of patients as compared to the other scheme, and then that becomes a kind of another reason for denial of care in those settings. So so I think that in terms of the design, if we can have a kind of a uniform structure of package, prices, and the set of hospitals that get empaneled, if they are empaneled for different schemes all working together, then I think that it also solves a lot of awareness issues and problems. But I think that this also leads to another work that needs to be done across the digital structures and platforms, which you are alluding to, I think, so sir, that when a patient walks in who has potentially multiple benefits, then which benefit kicks in first and which benefit kicks in the second. And if that can also be tailored in a way that enhances the overall efficiency of the system, then it becomes extremely important. One way in which perhaps the digital architecture is being used to possibly support some degree of convergence in terms of implementation and the overall claim processing, etc., is the creation of this new HCX portal within the ABDM architecture, the Ayushman Bharat digital architecture, where a common platform is going to be used, which is going to be used as an interface by insurers which are operating on different schemes. And this common platform can be used for by different hospitals, different insurers, different schemes that are operating on different package designs, etc. So I think that the digital architecture is getting geared towards such architecture and implementation. But I think that there is a lot of work still that needs to be done. One of the things that I think, sir, perhaps
Shankar,
a point that I
maybe we should take some of the questions in the chat.
sure, sure, sure.
Uh,
I'm
uh,
tempted. I only say about your digital architecture, let it come, Shankar, and then we'll talk about it. It's been coming for a long time.
Yeah,
I'm not at all confident that it is going to be in a functional form because it is being built on too large a scale. They could have incremented. They are incrementing also, but uh, I think if we don't solve the institutional mechanisms, digitization will not solve it. If the institutional relationships have been understood, digitization will expedite it. But don't look to digitization to solve what people can't. I mean, what if people are not willing to work with each other? Digitization won't solve that. These are risk pools of different power resources between them, different access to money and resources. So I think it will not work. And it's
yeah.
not a provider problem.
Mhm.
It's really a problem at another level. But let's look at some of these questions because we are going into a level which, yeah.
So we have Dr. Raman Kataria, who's He runs the Jan Swasthya Sahyog. He's typed a lot of comments and questions in the chat box. So, would you like to summarize your questions or comments by speaking directly?
Thank you, ma'am. Am I audible?
Yes, we can't see you though.
Yeah, my camera seems to be out of function. So
Okay.
I'll just, thank you, Dr. Sundararaman, for the beautiful exposition on this topic, and to Dr. Shankar for his comments and the discussion. I just want to point out some glitches, problems with the scheme, which already many of them have been highlighted. But I think it's important to say it here because I think I'm in front of these two people who have significant influence over the scheme. So I'm hoping that this message would be taken and some of these things would be cleared. So one is the major lacuna that we see in Chhattisgarh and Madhya Pradesh when we are working with poor tribal populations here in this area is the arbitrary marking of several packages as government reserved packages, which takes away several diagnostic packages. It's actually now come up to almost something like 35-40% in Madhya Pradesh and close to 30% in Chhattisgarh. They have become government reserved packages. And I think that it is mainly because, I'm just attributing it to this, but it's mainly because these were the packages which were actually being used more frequently by poor people. And they have been taken away from them and arbitrarily put as government reserved packages, whereas the government services have not pulled up to that level. So it's actually a denial of care for so many poor people in this area. So is there any way that this thing can be undone? Because and I think one of the ways, at least, which the way it can be undone is that at least non-profit hospitals, as Dr. Sundararaman talked about, Shaheed Hospital in Chhattisgarh or Jan Swasthya Sahyog also in Chhattisgarh, these hospitals, because they do not have the profit motive, they should be treated at par with government hospitals for these schemes. So that is one suggestion. The second is that you've talked about pan-India portability, but it seems to be only lip service because we have tried this with people coming from different states, including Maharashtra, Odisha, Telangana. They come to us, and it's a nightmare to coordinate with other states. Madhya Pradesh and Chhattisgarh we have been able to do because we were in touch with the bureaucracy there, but otherwise it's not possible to do any other state packages. The other thing for patients, which I believe is the identification glitches, of course, because of which packages can be denied. People, because they go on migration, their SECC during that period of 2012, they may not be part of the SECC. So that's gone. That means they've lost their lifetime opportunity of ever getting access to this kind of healthcare. The other is the lack of Aadhaar or an updated Aadhaar. So especially when you come in an emergency and your Aadhaar is not updated, it will take at least a week, if not 2 weeks, for your Aadhaar to get updated before you can actually book a package. So how does one book a package in an emergency? Many people, old people, for example, people who have received chemotherapy, they will lose their fingerprints and therefore they will not be able to access their Aadhaar, their entitlement. So I think these are, and of course, there are problems because many people do not own telephones. Poor people don't own telephones. So getting an OTP for verification is something which is out of the world for them. So I think there are several problems with this, including one is talking about the ABDM platform also. I think we should build platforms which are meant for the real world. Here in Chhattisgarh, depending on the connectivity that is available in rural areas in rural India. So I think these are some of the points which I wanted to say. Of course, there are several things about private hospitals also I wanted to say, but I think if one of you can respond to these.
Yeah. So this ID issue is a real bugbear. Aadhaar was said when it was introduced that once you have the number, you don't need anything else. Okay. And it is only if there is a challenge to your identity that you need to actually even show the fingerprint. That's the whole spirit of it. If there is a duplication. Where is the issue of duplication when you are sick? If you have an illness with TB, and why would you? Anyway, Chhattisgarh claims it has 100% coverage. Okay. If it has 100% coverage, what does it matter even on to have ID as an enrollment barrier on this. So the general principle requires to be that in the case of a missing identity, in Thailand it's a principle, so it's not as if it's a thing. That in case of a missing identity, it becomes the responsibility of the provider to give a temporary ID and then to link it up with the department to give you have 100% coverage. Somebody has come in without a card. He is the person, he is there, and therefore he is covered. So if he doesn't have an ID, it becomes your task to facilitate his getting his ID, not to use his lack of ID for a denial. So somewhere the ethics of this completely gets missing because you are using these as ways of rationing care. And in these forms of rationing care, the poorest get affected the most. So I think that this whole logic around this has. So when I was in the CMCHS committee, I went to place after place and I looked at all of it. And repeatedly, everywhere the rule was clearly stated that you should not be even requiring them to produce a physical card. Unfortunately, its violations were equally prevalent. Both the instruction was clear and its violation was clear. And it's very difficult to understand it except that these become forms of rationing in a situation where the actual demand far outstrips the ability to supply or the intention to supply. I don't know what it is. So I think this ID system can have easier solutions if the entitlement aspect is moved and the card's responsibility becomes that. So the third clause in the NSSO law is this: if they do not have a third or fourth in the first 7 clauses, one of them is if they do not have an ID, they will create a thing and then make the bridge with that, and then you will get the guy. So, in some sense, the worry should be if a poor man comes in without an ID, how come this person is still existing without an ID? How do we resolve that? That should become the first priority. So I think that's a mindset change that we require on this. And somewhere, the middle class is also complicit in actually wanting all these things, as if some person from some foreign country will slip into a Chhattisgarh public hospital and seek care. I mean, why would anybody do that? So in some sense, this sort of thing doesn't make any sense. But the other things that you are saying about reservation, unfortunately, Raman, there is a huge amount of moral hazard. There's a huge amount of overconsumption of certain elements of care that require reservation. But your point is very valid. And there are examples in Tamil Nadu and in other places where they have given public hospital status to private hospitals of an NGO mode who are working, especially in tribal areas, and you have established that you are one of the sole sources of access to these qualities of care. Unfortunately, the reverse is also true, and Zipper has a huge crib upon it. They give private hospital status to public hospitals for an entirely different complex set of reasons that really need to be unpacked also. But having said that, this flexibility that's public by other means. The issue is that it is not built around commercial profit maximization as a motive, but it is built around service care and is able to provide affordable care at that rate. So one of the indexes should be that if you are willing to offer this rate to all your patients, then you qualify for being given government status. It's a simple rule. It will work for Shahir because it's very difficult to differentiate between NGO and GO on the ground. Everybody will say we are not for profit, we are charitable, we are this. Maharashtra is full of philanthropic organizations which have no philanthropy in them. But the issue is, we can do it if we say that, look, this is the stipulation. Your rates that you are charging, and we will use HBP 2.2, Health Benefit Package 2.2 as the benchmark. If you are willing to extend that rate to all your patients, then and you claim you are an NGO, then we will let it go. Because HBP 2.2 is at opportunity cost. It's not at marginal cost. And if you can extend it to that rate, then you can do that. So there are solutions that are possible. And it's difficult to actually get them going. I must tell you, we don't influence policy. We do influence policy, but not in the way that we have power to do it. We act as sparring partners to the policy makers. They like to bounce their ideas off us and then do what they want. But anyway, they are informed in what they are doing. That much you can be assured.
Thank you.
Dr. Venkatesh, you also had a lot of comments and questions. Would you like to voice them? Dr. Venkatesh?
We had a personal statement from Dr. Bagdi in Maharashtra that a Tamil Nadu pensioner was not able to get coverage in Maharashtra. This is really an issue that the portability thing, and many have commented what I said in portability in the first line. In the first line is something like more like an intent. Portability across states is really very weak. And I know private providers who have told me, who are good non-for-profit providers, who have told me if they insist on portability, we are going to exit. Because the state government, we are somehow able to talk to them and get a conversation going. But other governments, we are not able to do. So portability is an issue. But beyond 70, if you are a pensioner, try to use that clause and get a card made in whichever state you are. Still very difficult, but it's a doable thing. I tried it and it worked for some people on that. But, that's also a lot of things. Yeah, yes.
So I think one just additional point, and before I hand it back to Dr. Sundaraman for the final concluding remarks, I think one of the points that I raised, sir, about regulation, and while you did mention that it's a much more larger area or body of work that needs to be done around different areas and institutional structures. What I perhaps meant at that point was that it is a nudging of the overall ecosystem towards a certain set of norms that potentially could be considered as better. So in a way, for example, the conditionalities that you impose on hospitals for getting empaneled at least is certain set of parameters that you set for hospitals to adhere to, or potentially creating some kind of standard treatment guidelines that the hospitals need to adhere to, or maybe even specifying the kind of the consumables, implants, etc., that would be paid for if the treatment is to be done to PMJY patients. In a way, also is a kind of a nudge, and the claims are going to be processed if those, for example, types of implants are going to be paid. So that's another one way I look at it that way. Incentives towards accreditation and giving some additional quality incentives is again something that we look at. And as you mentioned, that I think that one of the things that also starts to build in as a discourse as these schemes start to come in is that these also start to set the kind of benchmark pricing within the provisioning of healthcare services also. While it may not happen very directly, but I think that there is a certain reference point to always look back at. So I think in those at that level, potentially I was trying to hint at that there is some scope. So with those some additional points, I'll again hand it back to you for your final word before we hand it back to the organizers.
Yeah. So influencing provider behavior, private provider behavior by contracting and enforcing the contract is still feasible. Let me tell you, there is a great reluctance to enforce what is already written in the contract because you are afraid of exit. Okay. So, but we can get past that. We can do that. We are in a legal position and a moral position to do that. But when it comes to regulation outside the contractual thing, you come into essential legal objections. A private provider is like a private citizen, a right to ply his trade, to set a price, because he's not forcing people to take his care or refusing people. So, in some sense, to enforce an entitlement and a right with a private provider, the legal structure doesn't actually, you can't really do that within the Indian legal structure. So it is only the government that you can hold accountable. But you can significantly influence them if they have marginal capacity. Again, I emphasize, if they do not have marginal capacity, if they are full up, there is no reason why they must forego the prices they are charging to come into your deal. But there are so many doctors coming up. Many of them are unemployed. Many of them are startups. Many of them will be happy to start up doing a care, and you can find enough space to do that. So I agree with you that a persuasive form of regulation rather than a coercive form of regulation has a space that we need to really explore on that. But uh, we can't go back on this. I noticed Dr. Amalor's repeated comment that why do we need this at all? We can just do it with the public. It won't happen. And in some sense, there are reasons why it doesn't happen. The way is to go to the next step. You can't, we are in a situation, we can't go back. We have to go forward. And if we have to go forward, what is the best way to go forward? Because we cannot remain standing like Tamil Nadu is trying to do. Somehow manage to do its act and keep it together without changing anything. They know all the problems. We've only written it out to them. They found our discussion very useful, but to act on it requires a certain thing. So they'd like to retain the status quo as far as possible. But that's going to become difficult. But when you go forward, what are the ways forward is what I think we should direct. But I think potentially the way forward, if they choose the right ways, is quite exciting. We can actually achieve the right to health care much more substantially. We are in a better position to observe it today than in 2007. When I was in HHRC, we floated a bill which went very far. It was the furthest any bill went, but it didn't go through because of some practical difficulties. I think those practical difficulties are much less now. Potentially, a state wanting to do universal health coverage, right to health care can do so. The hardware is in place. The rest of it needs to follow.
Dr. Venkatesh, your hand is up. You wanted to say something?
Yes, ma'am. Am I audible now?
Yes.
Yes.
Thank you for such an enlightening discussion as usual, madam. And forgive my ignorance. I have a few questions for the panelists. One is, what are the advantages of the public-private partnership? Has there been any structured study has been done saying that we are moving in the right direction? That is question number one. And question number two is regarding the unemployment issue that we are facing right now, both from the Ayush ecosystem and as well as from the medical science, scientific medicine ecosystem. We have plenty of doctors coming out, and some of them are not in education, not in training, and some of them are not in employment as well. So what happens to these doctors is that they are not finding appropriate employment. And in this kind of a scenario, would it make a lot of sense for the government to build more hospitals and spend directly rather than kind of entering into public-private partnership, hoping that the private partner would actually bring in the infrastructure to the table?
There are lots of studies on public-private partnerships, and they just happen to be published in different journals. But at some point, a lot of peer-reviewed studies. Shankar Prinjay himself must be having a huge range of studies. I have my few on that. It's a very big bucket. There are many types of things. Let me try a one-line summary because I don't want to take very long. Where you are outsourcing support services, it's not doing badly. In fact, it's doing well. If you're outsourcing sanitation services, dietary services, etc. Ancillary services, a little bit mixed. But you have ambulance services, the dial 108 services outsourced across the country, still one of the largest PPPs in mode. And diagnostic services have been outsourced in some levels to some level. Imaging services are done reasonably well in outsourcing in Maharashtra, Tamil Nadu. So there is something. But when you are outsourcing the whole of hospital care and primary health care, the jury is still out. The best you can say is in niche situations where there is a motivated a husband, wife who wants to set up a CHC or a district hospital in a remote area, and you say, please go and take this hospital and run it, it does very well. Or NGO. But if you try to say, instead of the government, we will have PPPs running it, if a government cannot get a doctor or a specialist to come and work in a remote area, why will an NGO without the terms of security or the pride of being a government doctor or the terms and the pensions, all of that, be able to get it? They don't manage to get it either. But if, for example, it's a motivated person who wants to go there, do enable them. So in outsourcing of clinical care services, it's really out. Here, the niche examples are there, but scaling up has not been generally possible on that. In fact, the insurance PHFI is the largest form of PPP that has actually worked in terms of clinical care. And that is, I think, the major issue. Should government increase public hospitals? Yes, I think so. I think that definitely yes. And along with making the current ones more functional also and less crowded. But the real problem is on staffing. There is a proverbial reluctance to provide the adequate number of staff, which is a mindset of the 90s. So contractual labor, hired on very poor terms and understaffed, especially on the support side, nurses and the support staff. These are all major issues that we are facing. On the issue of unemployment, we give you a pass. Dr. Vidya, you have I think it's a good topic for a separate session. Unemployment in doctors, is it an issue or not? And there are some very good studies coming out on that, but I think it's a separate session. I won't even attempt to take that question now. Thank you.
Thank you, sir. One more question, just indulge me. One of the youngsters with whom I was talking to, who's a fresh graduate, he has been, not fresh anymore. He has been working for a couple of years now, but he has been employed in contractual basis with several organizations. So ESI, he was sometimes with ESI, he was sometimes with some other dialysis unit where he was working as a duty doctor, again, on a contractual basis. So he made one observation. Sir, I'm not able to give the full care to my patients because after 6 months, I'm no longer their doctor. Or 1 year, after 1 year, I'm no longer their doctor. So it kind of breaks down the continuity of care with the patients. So my pace, if when I leave, somebody else comes into this place. And this cycling of doctors is probably detrimental in the long term to chronic medical care and for chronic medical conditions. What are your thoughts on this, sir?
Yeah, I completely agree with you. The point about contractuality comes from an ideological mindset. But the problem with public services is they are permanent staff, and once you are permanent, you don't work. You get your salary whether you work or not. So keep them contractual, they'll work better. There's also about financing because you had pension liabilities and, pension, the number of pensioners in railways, defenses, central services is now more because when we started pension, people's life expectancy was 65. Now our pensioners live till 95. So therefore the total number, so these pension burdens. So this is really a problem coming from finance and from ideology. I think we need to recognize that people with good social security need not be permanent, but good social security and tenure at a certain amount. At least give them 5-year contracts. Why can't you do that? And at some point, and with a career plan is the best way to go forward. So it's not about building more buildings. When they say hospital, we are all too ready to build 16 AIMS. Now everybody wants an AIMS, but none of these new AIMS has even half the complement of staff it needs. So you're building, the interest is in infrastructure and not in staffing, and that mindset changes. It's a huge. And believe me, if you ask economists who are of a different ilk, they will tell you that actually providing more staff is a very good form of demand management and will actually improve the economy. So it's not even true what the finance secretaries are thinking that by keeping staff contractual, you are getting better work and making more efficient use of money. That's not really true, but that is the mindset. And unless we are able to break that through, there's a problem. And there is a problem we also need to reform government services to make sure that some of the concerns are there. But
Thank you, sir.
contractual is not the answer. That is very clear.
Right. I'm really sorry. There are lots of comments and probably some questions in the chat box which we are not able to address, but we are really out of time. So I must thank everybody who made it to this session. Maybe it went over some of our heads. Maybe people may have thought something else is going to be discussed, but definitely we will do a follow-up of this program where it will be more like from a practicing doctor's point of view, how these publicly funded insurance works and how do they navigate through channels, irrespective of whether they are working on their own or they have a small nursing home or they work in a corporate hospital or they work in a public hospital. So one of the questions I had planned for Dr. Sundararaman was, what is this joke about using PMJ card in a public hospital? And the points that you made, I've heard from the friends who are working that, oh, thanks to this, we were able to buy this fantastic equipment, or thanks to this, we were able to get more cleaning staff, or thanks to this, we were able to retain people from, resigning, especially so otherwise, things like that, which actually directly are more understandable. Maybe we'll do another session where people's direct questions can be answered, which they are facing in their everyday life, rather than the overview that you both have planned and given us a taste of. So thank you both, Dr. Sundararaman and Dr. Shankar Prinja, for very sort of giving us a full overview of what is going on in the public funded health insurance scenario. So we, as suggested by Dr. Sundararaman, we can do some other follow-up sessions in the coming months about other types of health insurance like the ESI or whatever contributory type of insurance. So again, next week, incidentally, next week we will be having Dr. Raman Kataria, who runs the Jan Swasthya Sahyog. He's going to talk about his experience of starting and running in a remote location. So I hope that many of you will log in next week as well. Till then, please take care and good night to everyone.